All right, good morning everyone. Thank you so much for joining us today. We look forward to talking with you today about chlamydia screening guidelines and implementation strategies. We have Dr. Ina Park with us here today as our expert faculty speaker. All right, without further ado, I would like to introduce Ina Park. Dr. Park is an associate professor at the Department of Family and Community Medicine at the University of California, San Francisco School of Medicine. She also serves as medical director of the California Prevention Training Center and a medical consultant to the Division of STD Prevention at the Centers for Disease Control and Prevention. Following her residency in family medicine at Kaiser Permanente, Los Angeles, she completed a fellowship in sexually transmitted diseases at UCSF and here at the California Department of Public Health. Dr. Park recently was a co-author of the forthcoming 2020 CDC STD treatment guidelines. All right, thank you, Ina. My pleasure. Hi, everybody. It's nice to see lots of, let's go over a roadmap of where we're going today. So by the end of this webinar, you'll have hopefully more knowledge around national recommendations for chlamydia screening and management. So we will talk about epidemiology, we'll go into risk factors, symptoms and adverse outcomes, and recommendations for screening based on age and gender. And then, how to manage infections, and that goes from just the basic treatment of patients to their partners, and then retesting after to check for reinfections. And then this, I think, is the meat of the presentation, is really how do we get this done. I think what we need to do is actually pretty straightforward, and how to get it done is much more challenging, as I think many of you will attest to. So we're going to talk about some suggested protocols to facilitate chlamydia screening, and then show a whole host of products that have been developed to support your practice around this. Okay, it's no secret to anybody on this call that chlamydia rates are rising nationally, and you'll see this is national data of cases reported by males and females. Unfortunately, other gender minorities such as transgender folks are not included here in the CDC data, but you'll see that the rates for women are quite a bit higher than for men. And that overall, the trends for both genders studied here as well as the total are increasing nationally. But, as you can see, chlamydia is not distributed equally throughout the country, and you'll notice that the areas that are very light yellow are, really places with very low rates of chlamydia, going all the way to the very darkest blue, which are the states and areas with the highest rates of chlamydia. And you'll see, of course, that California and most of Louisiana, as you'll see, is pretty dark blue. California, both the coastal and inland regions are also pretty dark blue as well, representing very high rates of chlamydia, and many of you guys are located here, which we're going to show you in a second. And it's interesting because this is different for things like infections like syphilis, but really chlamydia is rising everywhere regardless of region, and of course you will see some regional variability with the South having slightly higher rates, but as you can see, it's not good anywhere and it's getting worse. And I think this is probably one of the most powerful slides in terms of showing the disparities here by age as well as by gender. And so there's some animation here just to highlight in this pink box that you'll see that adolescents and young adult women in these age rankings and gender rankings are by far the most impacted by chlamydia. Of course, young men are affected as well when you look at the age categories of 15 to 24-year-old men compared to other age groups. But you'll see that they're quite a bit lower than what we see for women, and part of that is likely due to the fact that there's really no routine screening recommendations for men in all settings, and we're going to go over that a little bit later. So some of that probably has to do with the fact that men are not screened for asymptomatic infection as much, but even when we look at studies that actually take groups of men and women that are asymptomatic, you still find more chlamydia in women. So probably some real differences there. But another disparity that I think is important to point out, which unfortunately, as you can see over time, is not changing much either, is the disparity by race and ethnicity. And so you'll see that blacks have a much higher rates of chlamydia than whites and Asians, And then, of course, Hispanics are a little bit higher, and Alaska Natives and American Indians are somewhere in the middle. You know, these trends, if you even go back beyond in the past, before 2014, you know, very, very similar trends. And in fact, in places like California, the disparities have even been worse than this in the past, and have been getting a little bit better over the past few years. So not to leave our Louisiana colleagues out, and don't worry, we'll get to you as well, but just wanted to point out for those of you who are sitting in California, chlamydia rates have been increasing for many years. These are data going back all the way to 1990. And these are data through 2017, but we have the 2018 data coming in a little pop-up here. So as you can see that the 2018 case count for chlamydia was over 232,000 cases. That was the highest number actually reported in the state of California in the past 25 years, I believe. Holly, I'm looking at her and she's nodding. And so, you know, on volume and sheer number of cases, California wins because we're just simply an enormous state. But not to leave our Louisiana colleagues out, Louisiana chlamydia rates are also very high, and in fact, the rate in Louisiana is higher than it is in California. So the rate in California, if I go back one, was about 583 cases for every 100,000 folks in the population, and in Louisiana, it's almost 800. So in fact, Louisiana had the highest chlamydia rate in the United States, the second highest chlamydia rate in the United States. And who was number one, Holly?
I don't know. I should
Me
know
neither.
That.
We're going to find out who the winner is and let you guys know later. But one of the things that I wanted to hone in on, because we did show a national map, heat map, showing high rates of chlamydia, but particularly, I'm going to start with California first. There's, you know, big disparities among various counties in California. For those of you who are sitting in LA County right now, as I know that that's one of the counties that's involved here, there are very, very high rates of chlamydia, particularly for youth 15 to 24 years of age. You know, we'll also see counties at the border affected and coastal and inland communities. So it really is, in much of the state, very high rates of chlamydia. And you'll see that your eLC practice site is highlighted there. Most of you are in a chlamydia hot zone. And then for those of you in Los Angeles County, based on your service planning area, you'll know that there are higher rates of chlamydia in the southern and central parts of the county, and the eLC practice sites that are located in those areas, as well as in other parts of LA County, are highlighted here with the blue stars. And another thing I wanted to point out is that there's, you know, certainly similar disparities seen across Louisiana. So these are chlamydia diagnosis rates by parish, and Orleans Parish, where one of our eLC practices is located, which is seen in this hot pink star. As you can see in the very dark red that you notice here, also has very, very high rates of chlamydia, one of the highest rates in the state. Okay, and so we're going to get into something that I don't know that, I think everyone on this call already knows why chlamydia screening is important, but I'm not sure if everybody on the call knows that chlamydia is the most common reportable communicable disease that is among all the reportable conditions to CDC. Chlamydia is the king, gonorrhea is the queen at number 2. So incredibly, incredibly common. It is, you know, curable usually with single-dose therapy, and curing, obviously, the infection will prevent complications later on down the line, which we're going to talk about in a later slide. One thing we want to talk about in terms of chlamydia screening being important is that the highest rates are among adolescent and young adult females, age 15 to 24. When repeated chlamydia infections happen, you'll see that the sequelae of those can lead to permanent and lasting problems with reproductive health later on. We're going to talk about that more specifically in later slides. And then, the serious health outcomes here can affect things like life-threatening conditions like ectopic pregnancy, as well as pelvic inflammatory disease. And so these are pretty serious outcomes for an infection that is, often asymptomatic and incredibly common. So hopefully I've convinced you that it's important for us to pursue this. And so I apologize if the type is a little bit small here, but I wanted to walk you through because I know that we have folks that are both providers on this call as well as folks that are clinics and other support staff. And so I just wanted to point out that for females, so these are cis females, folks that have a cervix, you can get infection with chlamydia causing inflammation of the cervix or cervicitis, which I'm going to show you a picture of. It can also affect the urethra of the penis, which causes urethritis, and can infect the rectum, causing proctitis, or infect the eye, conjunctivitis. If that's untreated, you can lead to complications such as pelvic inflammatory disease, and that can cause inflammation in the fallopian tubes, which is called salpingitis, or in the uterus itself, endometritis. And then you can actually get inflammation and even abscess formation around the liver, and you can also get a secondary kind of arthritis after having a chlamydia infection, which is called reactive arthritis. Pretty uncommon, but just something for folks to know about. And then we already touched on the bad outcomes that we want to avoid here, which are things like infertility and ectopic pregnancy, pelvic pain. And for folks that didn't know, chlamydia can also increase your risk of both passing on and acquiring HIV. And then, again, arthritis and chronic problems with arthritis is pretty rare. Now, for males, all the same things can be affected, minus the cervix. It's unusual, I would say, for men to have complications from chlamydia. It's not fair, but that's just the way it is. You can get inflammation of the epididymis. If you were to have that happen multiple times, you could have issues with fertility, but again, it's very uncommon. And the complications and sequelae are pretty similar for men and women, but you'll see that for men, they're much less because they don't have, it really doesn't ascend into the upper tract as much and cause problems. And then for infants, which we're not really going to touch on much here in this talk, honestly, but I just wanted to mention that, infants born to mothers who are chlamydia positive can have eye infections, lung infections, pharyngeal infections, as well as infections of the upper respiratory system. And, there's, usually they're identified and treated, and there's not tons of long-term sequelae usually associated with these. I'm going to move on. Okay, so I think one of the reasons why chlamydia screening is so important is that chlamydia is most often asymptomatic. So we really can't wait for people to come in to see us and say, oh, I have discharge and I have symptoms, because most of the time that's just not going to happen. And there are some differences here. This is for data based on cisgender females and cisgender males, that for females, we would say a good way to think about it is that the majority of females are asymptomatic, and depending on the study, it's like 70 to 95%. If somebody does have symptoms, they can present in all different kinds of ways. I just had a patient who presented just with some spotting after having sex. That was her only symptom. She didn't actually notice any difference in her discharge, and she definitely had chlamydia. Some people can have a change in their vaginal discharge. They can notice that their period actually becomes heavier or more prolonged. Spotting after sex, painful periods, or painful sex can also be presentations. But again, most of the time, people will not have any sort of physical symptoms or presentation with their chlamydia infection. It gets a little bit trickier for men because it really depends on the study that you're looking at in terms of which proportion of men are asymptomatic. So this is a twist on the common teaching that I received in medical school and in my training, was that, oh, men are going to be symptomatic and women are asymptomatic, and that's really not true. There are studies that actually show that in those particular studies that a majority of men didn't have symptoms and actually had chlamydia. So it's certainly possible, and I think a good way to think about it is that men are more likely to show symptoms, but they're certainly not guaranteed to show symptoms, and men can certainly present with chlamydia and not have any symptoms at all. So if they're going to have symptoms, they're pretty obvious. They have burning when they go to the bathroom. They also have discharge from the penis. And there you go. So the chlamydia screening recommendations, are generally harmonized, a little bit different for the American Academy of Pediatrics. We have them all here. Most folks, including the AAFP and ACOG, CDC, and the United States Preventative Services Task Force, say to screen all sexually active females less than or equal to 24 years of age and other folks at increased risk. And most of these documents, guideline documents, then highlight who is at increased risk, and we'll talk about that as well. Now, AAP, the Bright Futures recommendations from the American Academy of Pediatrics, is a little bit different because it doesn't really give an age limit. It just says anyone who's sexually active, any sexually active youth should be screened at least annually. But it's nice that most people agree that folks should be screened at least annually. And so dividing up folks into these buckets of, who gets screened and how often, et cetera. So for females, cisgender females, under the age of 25, so basically 24 years of age or younger if they've ever been sexually active. And if they're over 25, then basically if they're at risk. And we'll talk about what at risk means. All pregnant folks under the age of 25 and pregnant folks if they're over the age of 25 if they're at risk. Now in the state of California, actually everyone gets screened for chlamydia and gonorrhea regardless of age, but these are the national recommendations by CDC. So for men who have sex with women, there's no routine recommendation to screen men who have sex with women. And every time I think about this, it irritates me because women who have sex with men are getting chlamydia from somewhere, and I assume it's from men who have sex with women. So why we don't screen men who have sex with women is, always been a little bit of a mystery to me. What I've heard is that it's based on the fact that the cost effectiveness data did not appear to be good enough to make a national recommendation for this. With chlamydia rates increasing, I wonder if this will change someday, but for now, high prevalence settings, so certainly teen clinics, family planning, STD clinics, those types of settings where there's high prevalence of infection are certainly recommendations, correctional settings, et cetera. For men who have sex with men, regardless of age, chlamydia screening is recommended at least annually, and the sites recommended basically all sites of exposure, so genital, rectal, and pharyngeal. And there wasn't a pharyngeal chlamydia screening recommendation in the past, but there is likely going to be in the future. And then this piece is really important here in the fuchsia, down in the lower right-hand corner, is that once someone is infected with chlamydia, they are likely to get it again. And so everyone should be retested 3 months after they've been treated for their initial infection. And you're going to hear me say this a couple more times because it is really one of the most important pieces of chlamydia and trying to control infection. Okay, so remember I promised you that I was going to talk to you about what the risk factors were, because when we talk about screening older women, which is women 25 years of age and older, and they say screen people at risk, what are the risks? Well, age is certainly a factor, but for people who are 25 years of age and older, if you're trying to figure out whether or not they should be a candidate for screening, have they had chlamydia or gonorrhea in the last 2 years? Have they had more than one partner in the last year? I think this is actually really important, the fourth bullet, which is, did their recent sex partner actually have a partner at the same time that they were having sex with them? And so this is actually something that Holly, who you just heard from, worked on for several years, and that's really asking, somebody who says, well, I only have one partner. Well, is it possible that partner has other partners? And if it is, then that is someone who should be screened for chlamydia. Any exchange sex, so money, drugs, shelter, housing, and folks who live in a high morbidity area. Some high morbidity areas recommend, screening of women beyond the age of 25. So I'm going to show you some pictures, and then pretty soon I'm going to my first poll. But the normal cervix is on the left. The cervix on the right, you'll see, is red. We call that erythematous. You can see some discharge, which looks sort of like pus coming out of the center or the os, and that is cervicitis caused by chlamydia. It can also be caused by gonorrhea and other STIs. So this this is an example of sort of what happens with pelvic inflammatory disease. So let me tell you what we're looking at here. So if you can imagine somebody standing in front of you who's wearing a pair of pants, and you were to sort of slice their waist at their waistline, and you were to open up the torso and look down inside the pelvic bowl, you would see the top of the uterus, which is right here, and then you would see the fallopian tubes coming out almost like arms extending from your shoulder. And then basically in the armpit here, you see this nice ovary. And then I'm going to go to show you what happens. You know, on the right side, this is what happens during pelvic inflammatory disease. And, you know, one thing I wanted to point out is that pelvic inflammatory disease sometimes has symptoms, but it can also happen subclinically without any symptoms. And the scarring like this, extensive scarring can occur even if someone never recognized that they ever had PID. And so you'll see here on the right that the normal anatomy is quite distorted, and these, you know, thick bands of scar tissue are almost, when you have to burn through them during the surgery to try to free up for someone who's got infertility due to adhesions from PID, this is like duct tape. It's very fibrous, it's very thick, and you can see how it would distort the normal anatomy and how someone could end up with infertility because of this. So we're going to talk about what are the recommended specimen types for chlamydia, and nucleic acid amplification tests are pretty much all that's being used these days. They're very sensitive and specific, meaning they don't give a lot of false positives and they don't give a lot of false negatives. They're much less dependent on the perfect conditions, like culture requires very, very specific conditions. The organism dies quickly. Nucleic acid tests, you know, the material that you're testing is stable for a really, really long time at room temperature. The optimal specimen type is a first catch urine for men. Back in the days, I don't know if any of you guys have been in practice long enough to remember, we used to stick a little swab inside the urethra, and men really didn't like it, and many of them would never come back to see you because it's very traumatic. The self-collected vaginal swab is a great specimen in terms of it's very sensitive. It's the most sensitive compared to urine. That being said, if you have a great urine-based screening program, I would say keep going with that. If you're interested in switching over to a different specimen type, the self-collected vaginal swab, women are very good at collecting them. There's high patient satisfaction with it. They, you know, generally report that it's easier or the same in terms of ease of collection with urine. So it's, if you're considering going there, you will get a little bit more sensitivity with the self-collected vaginal swab. And then, of course, nucleic acid tests are recommended for detection of rectal and oral pharyngeal infections, and they were FDA approved last year. So it's pretty straightforward what to do if you actually end up with someone with chlamydia. Go ahead and treat them, and the recommended treatments are Zithro 1 gram or doxycycline 100 milligrams twice daily for 7 days. And for pregnancy, there's really only one recommended regimen, which is azithromycin in a single dose. Well, what if you're not going to use one of the recommended regimens? Are there any alternatives? Sure, you can use, there's a delayed release doxycycline, which has a little bit lower GI side effects. It's much more expensive. It is equally efficacious. That would be a once-a-day dosing of 200 milligrams. And then there is an alternative regimen in pregnancy, which is amoxicillin. We generally recommend to go with azithromycin unless there's an allergy situation, because there are some data from the laboratory that show that the chlamydia can persist if treated with amoxicillin. So that's why it was moved to being an alternative. Also pretty straightforward. If you have one STI, you're likely to have others, so go ahead and test folks with chlamydia. They'll also probably be tested for gonorrhea at the same time, and test them for other STDs, including syphilis and including HIV. So, and if folks are positive, you definitely need to treat sexual partners. So I am curious, I'm going to go over each of these methods, and then I would like to ask folks to use their little figure at the top to vote on either agree or disagree. I'm curious if you've ever seen a patient or a client in your setting who has brought their partner with them to the clinic when they were treated for chlamydia so that their partner could get treated at the same time. So this is called concurrent patient-partner therapy. So far we have slightly more people who've actually seen a client or patient do this and a few people who haven't seen this. And I'm going to tell you, this is evidence-based. I know of 2 studies looking at whether or not this is an effective way to get partners treated. I will tell you it works pretty well if somebody has one main partner, and once they hear that there's chlamydia in the partnership, if they're still willing to speak to that partner, because sometimes they're not because they're very angry, and wondering how chlamydia got into the relationship. But this doesn't work that well if someone has multiple partners, and I'm going to tell you that this, from personal experience, where I told a patient to bring in their partner and they brought in both partners, not letting either of the partners know that there was another person involved. And so the 3 of them sat there, if I'm the patient and Holly was one of the partners, and then another partner sat on the other side, and they were just all staring daggers at each other in the waiting room. So I recommend for just one main partner, not for multiple partners. Not a good time to figure out that there's somebody else that your partner is sleeping with in the waiting room of the STD clinic. I don't recommend this. So what about other methods of notifying partners? And one way is, a little bit more passive, where the patient's sitting in front of you and you say, you have chlamydia, tell your partner to go get treated. And sometimes the response I get to that is, well, they should just go take care of themselves. I'm not going to let them know because they're really upset. Sometimes they're like, okay, and I'll let them know. But I have no idea once that person leaves whether or not they actually give the information, and whether or not then there's the other step is, does the person actually go in and get treated? And so these other methods that I talked to you, which is sort of like bringing your partner with you when you get treated, or giving expedited partner therapy, are certainly more expedient ways to get it done. And we're going to go over the evidence to demonstrate, at least for expedited partner therapy, that it appears to reduce reinfection. Certainly with gonorrhea, this is statistically significant. This is a study from the New England Journal, and it's now more than 10 years old, but a large randomized trial of looking at expedited partner therapy versus usual care to reduce reinfection. For chlamydia, it wasn't statistically significant. It was a little bit lower, though, 11 versus 13% reinfection rates. So the legal status of expedited partner therapy. So I've been in this field for 12 years, and I have to say this map has changed so much since I entered. And Holly, who's been here even longer, probably can attest to the fact that it's really, really morphed. So expedited partner therapy for chlamydia was sort of made legally acceptable in 2001 in California. For gonorrhea, it was 2007. I actually am not sure when it came through for Louisiana, but it was definitely after that, after California. But you'll see there's very few states now where expedited partner therapy is not legally allowable. And the thing is that there are barriers even when it is legally allowable. Certain places like federally qualified health centers, because of the Federal Torts and Claims Act, are sometimes not able to give therapy to partners that are not actually patients of the organization. And so even though it's legally allowable, there are major structural barriers to getting it done. I wanted to highlight that folks in California do have access to free medication distribution program. The California Department of Public Health helps fund this through Essential Access, and I know Essential Access provides free prepackaged medication to eligible clinic sites and local health departments, and those prepackaged medications also have instructions about warning signs and about what is chlamydia or gonorrhea for the patients and their partners. And the patient would give the medication directly to the partner. And the practices that are on this eLearning collaborative may be eligible. You'll get these slides, but there's a website with a link to Essential Access in the program. Now in Louisiana, they don't have access to a similar program as far as I know, and I did ask Holly and Ellen about this. You know, right now, my understanding is that folks in Louisiana would probably write a prescription for the partner and then hand it to the patient to pass it along. We have some resources, and these, you know, some of the principles behind patient-delivered partner therapy are certainly not California-specific. There are guidelines on the California website. Essential Access also has some guidelines that I think could be applicable in many ways to anyone in the United States. There are certain state-specific things, of course, in there, but I wanted to sort of highlight the fact that these exist. And then one thing I wanted to point out is, you know, sort of a wrap up of what we talked about is that for partner management, if you're treating someone for chlamydia or gonorrhea, obviously if you can get the patient into the partner into clinic, that's ideal. Barring that, concurrent patient-partner therapy, you know, asking someone to bring their partner in, works well if you have one partner. If you have someone, you know, who's not going to bring their partner into clinic, then expedited partner therapy certainly works well. There's randomized controlled trial data that show that it reduces reinfection. For folks that you're not going to be able to treat promptly otherwise, I think it's a really great strategy. Offering medication to patients is the most effective, but giving a prescription is also a good option. And so before I get into this, reinfection, which is one of the important pieces of this talk, I wanted to know how many folks out there, if you could raise your hands to agree or disagree, have worked with a client or a patient who's had chlamydia twice or more in 1 year in a 12-month period. And I'm going to raise my own hand because it's definitely, I just saw patient 2 weeks ago actually, who had multiple bouts of chlamydia, actually more than 2 in the past year. So people have seen someone who's had chlamydia more than 2 or more times in the past year. And this next slide that I have up here on the webinar screen right now highlights a couple of pieces of information about repeat infections. So repeat infection is common, and it's certainly more common in folks who've already, folks who've had repeated infections are more likely to get repeated infections in the future. So if we take clinics, so these are family planning clinics in the state of California. If you look at the baseline positivity by age in the clinic, and then you look at those who, that the baseline positivity is at a certain rate, you can see it goes from 6 to 1% depending on age. And then for folks who've already had one chlamydia infection, you'll see that the repeat infection rate is so much higher. It's anywhere from 9 to 12 times higher in certain circumstances. And so regardless of age, reinfection is much, much higher. And then for the 31 to 35-year-olds, there's a 12-fold difference. And the thing about reinfection is that there are lots of negative consequences. And remember, we talked about the complications of untreated chlamydia infection, is that every subsequent infection with chlamydia increases your risk of these adverse outcomes such as PID or ectopic pregnancy. And so if you have a second infection, your risk of PID increases by 4-fold, and your risk of ectopic pregnancy doubles. When we get into a third infection or more, then it becomes a 6-fold risk of PID and a 5-fold risk of ectopic pregnancy. So these are just take-home points. Of course, the sooner we catch people in terms of screening them and treating them early on, the less likely this is to happen, even if people do have repeated infections. So what you guys are doing out there with improving chlamydia screening and retesting is, incredibly important. And so point number 4 in terms of what to do with a patient who's positive for chlamydia is retesting. So this is one of the most important pieces of this whole puzzle here in terms of controlling chlamydia infection rates. It's recommended for all patients who test positive for chlamydia or gonorrhea, and also trichomonas, just to throw it in there, 3 months after treatment, Or you could test someone, if they're not going to be coming back at 3 months, but they came back at 2 months, or they came back at a month, it's fine to test them opportunistically when they show up. The timing is tiny bit tricky because there are dead DNA and RNA from chlamydia hanging around, so you've got to wait at least 3 weeks from the time that they were first tested and treated to the time that you repeat the test. 3 months is ideal. You can test them anytime after 3 weeks. Retesting is really, really important for adolescents because they, as you remember from the slide I just showed about reinfection rates, they are most likely to get repeat infections. They're the age group most at risk. So one thing that I wanted to point out is that repeat testing is not the same thing as a test of cure. So repeat testing is, the point of it is to identify people who get reinfected. So you see somebody and you treat them with antibiotics. You tell them, wait for 7 days to have sex again. You know that as soon as they walk out the door, some people wait and some people don't, and some people use condoms and some people don't. And so reinfections happen immediately, but we want to catch them early enough so that hopefully we're preventing any complications down the line. So that's different than a test of cure. So when I order a test of cure on somebody, it's because I'm using a different antibiotic regimen that's than normally recommended because they have allergies or because they're pregnant. And what we're doing with a test of cure is really looking at, did the antibiotics effectively clear the infection? So it's a little bit different, and it's the same test that you order, but the reason that you're ordering it is different. And so really we only order a test of cure in women who are pregnant 3 to 4 weeks after therapy, and a non-pregnant female if you're using a non-standard regimen, or you feel like they didn't take their antibiotics, there's a compliance issue, or sometimes people come back and say, I'm not any better and I didn't have sex again. So that's another time that you do a test of cure to see if their chlamydia is cleared or not. Okay, so retesting rates are very, very poor. I don't have exact numbers in front of me, and bet Holly might have some on the top of her head, but they're not good. But there's a lot of reasons why retesting rates are low. And there's practice level reasons. So that would mean the patient shows up and no one knew they were due for a retest, and there's no sort of flagging system in place to say, oh, patient had chlamydia, 3 months ago, the patient's due for a retest. Then there's all these patient level issues that come into play. The first might be, I definitely give the spiel to someone when they have chlamydia, that it's really important to come in to get retested, and some people may or may not receive that information, so they might not understand that it's important. Then there's also, they know it's important, but they just space out and they don't come back for retesting. And then there's also, they'd like to come back for retesting, but they have barriers to getting to you, such as transportation, et cetera. And then there's, sort of organizational or agency level issues in terms of, no policy sort of prioritizing this, and the staff aren't trained and didn't know that this is important. And so there's effective ways to counsel people, to let people know why they should come in, why they should prioritize it, and how they can do that, and which is setting a cell phone reminder or setting some sort of reminder system in place so that they'll come back. So how do we get this done? These are the most important pieces. As I told you, the what is not that hard. The how is more challenging. So adolescents should have alone time with their provider, very important. Documenting chlamydia tests and results in a confidential location in the EHR is key. And then one thing about, if you test a minor patient for any test covered under minor consent laws, including chlamydia screening, it's important to have private contact information for the person where you can reach the patient directly with their results. And I would have to say majority of our adolescent patients do have a cell phone. If you guys feel like that is, and I think that's probably the case. In the interest of time, I think we'll clear this poll and move on. So another tip or trick to ensure routine chlamydia screening is really standardizing practice and protocols. So take it out of a provider's hands and put it into the system. So that means taking a urine sample at standard of practice at every well-check visit for folks at, starting at whatever age you want to start at. So we wrote 12 to 15 here, up to 24 years of age. Routinizing chlamydia screening on folks who are doing a urine pregnancy test. You have a urine anyway, and going ahead and doing a same-day chlamydia and gonorrhea test. And then for folks, many of folks on this call also doing a syphilis test at confirmation of pregnancy or at a positive urine pregnancy test. And then here's an important piece, is basically for walk-in visits. At check-in, the receptionist would review when is your last well child visit. If it's been more than a year, let's screen today and then schedule a well child visit with the patient and the parent at that moment when you have them and they're a captive audience. So other tips and tricks in California, folks can give patients educational materials and enrollment support if it's possible for Family Pact, which would cover these services. In Louisiana, it would be Take Charge Plus to facilitate confidentiality and financial coverage for these services. And of course, Take Charge Plus folks are not going to be able to issue a card on the same day, but when the coverage comes into effect, then services in the prior 3 months will be covered, and Family Pact folks can get a card on the same day. EHR chart flags alert staff when patients are coming in and due for screening. Those are actually effective, although staff do find them annoying. They do work. And then a designated chlamydia champion. You'd be very proud to wear that badge. Keeping staff up to date, being your STD person, your knowledgeable person who keeps people up to date on recommendations and monitors these things and keeps tabs on them. And some of the chlamydia champions will be talking in a few minutes, which I'm excited about. And then one thing I just wanted to tell you that's happening is something called opt-out screening. It's actually being tested in a study in Pittsburgh right now. This is the traditional model that I've talked to you about. Let's ask people about sexual history, order a test, and but it's important for providers, still have to order it and people still have to ask. What's being tested right now is sort of an opt-out model, which is regardless of sexual history. So in some circumstances, they don't take a sexual history. They just order urine on everybody in a certain age range. And then, have them universally collect either a vaginal swab or a urine, regardless of sexual history, and then basically everybody gets screened unless they've had a negative screening test in the last 12 months or the patient refuses. And so there's like a little script to say, in this practice we screen everybody in this age range for chlamydia, and the patient has to refuse verbally to not get a chlamydia test.
I was just going to say, I believe some states have actually opted for this. I know New York State, the Medicaid program in New York State is actually now recommending this for all of the health plans.
That's fascinating. Yeah, and I don't know of other states that are doing that, but I know that that study is going to be ending soon. It'll be interesting to see what they find.
What the results are.
Yeah. So screening and management in a summary: screen for chlamydia, screen for syphilis and HIV if they're positive, test and treat, treat patients, treat partners, and retest again in 3 months. And so this is just a summary of everything that we've discussed. I think for the interest of time, if it's okay to skip this.
Mm-hmm.
But I wanted to point out the clinical tools and resources because I think lots of practices need support and other tools to figure out how we're going to get this done. We know what we want to do. How do we get there? And so this is a toolkit about sort of why to screen for chlamydia and an implementation guide for healthcare providers from the Chlamydia Coalition. And this is a Family Planning National Training Center, which is a chlamydia screening change package, which talks about how to include chlamydia screening as routine clinical preventive care, and examples of language, as well as what test types to use, et cetera, and talks also about payment options. And then another piece of the toolkit, which we're showing here, is the Family Planning National Training Center kit here. The website is here as well. Lots of really great resources there. Is this the one that also has scripts for providers?
Mm-hmm.
And that's nice because if you're not used to doing it in a primary care practice, then it's nice, what do I say? What do I ask my staff to say? This kind of stuff is in here. And here's more screenshots of what it looks like, very professionally produced materials. Definitely recommend it. The National Coalition for Sexual Health also has a great toolkit for providers that you can go to with very practical tools and how to respond. Again, more scripts about how to respond to patients' questions. And then the University of Washington STD Prevention Training Center has posters for how to collect your own vaginal swab. If you see men who have sex with men or transgender women who have sex with men, it also gives you, they have posters on how to collect your own pharyngeal and rectal swabs too. So lots of great resources available for free, and the contact information is at the bottom. Then, of course, we would be remiss if we did not highlight the National Quality Improvement Center, QI Resource Library, which is, the link is here. Many, many other tools. Links to all of these tools are there, of course, and other homegrown tools that are fantastic as well. And there's an app for everything, including for STD treatment guidelines. This app will be updated with the 2020 guidelines next year, but the app is available for both Android and Apple devices for free. And for those of you, probably not going to ask so many questions for chlamydia, but if you see syphilis or complicated chlamydia and PID questions, please send them to the STDCCN at stdccn.org. And myself and other faculty answer these questions on a daily basis. We would love to hear from you. And we're going to look at some of the questions in your chat box in the few minutes that I have left.
That's the only one we have so far from Dr. Dixon.
Well, and then it looks like Mary asked if we give adolescents access to their chart, we get their number too. Right, that's great. And Sherry Dickstein asked why not do urine CT for anyone who comes in for a pregnancy test, regardless of whether or not the test is positive or negative.
Sure.
You know what? That's a great idea.
Yeah.
Because certainly they've had unprotected sex.
Right.
If they're asking for a urine pregnancy test. So I think that's brilliant.
There was actually a study in the Title X program a number of years ago, probably over 10 years ago, that actually looked at that. And it was chlamydia testing, chlamydia and gonorrhea testing during just pregnancy test-only visits, regardless of the result, and showed incredibly high rates. And you're right, we know they've had unprotected sex.
Right.
That's why they're getting a pregnancy test. So yes, that's absolutely right.
Right. I love the idea. Thank you. That's very creative. We have not implemented that in our STD clinic, although most people are getting a vaginal swab anyway. But I like that idea of just running both, UPreg and the chlamydia on the urine. I love it. I'm going to
for participating today. Thank you to Ina.
Thank you, everybody.